So we've known for a long time that insulin alone is not sufficient for many of our patients. So, less than a third of our type 1s get the sort of glycemic control that we and they would like. And it's not just the effort that's required for insulin adjustment, for the regular testing and adjusting insulin, but also physiologically they're on a losing wicket because they're injecting insulin into the wrong space. They're injecting it peripherally rather than portally. And then the minute-to-minute variation in insulin that's required can't be reproduced with either MDIs or pumps. So it's very difficult to try and achieve good glycemic control. So we've known for a long time that we need help, other therapies we can give. And of course we've experimented with other therapies over the years. So we've looked at alpha cell blockade, so anti-glucagon, therapies that work through glucagon, GLP-1, DPP-4s. We've looked at therapies that act on the liver, like the glitazones and TZDs. We've looked at therapies that act on muscle, like exercise, and the gut, like acarbose and bariatric surgery. And in this, and we've had variable results. Not all of these are licensed, of course, and we've had variable results. These two trials we've been waiting for some time because they act on a non-insulin axis, so regardless of whether people need insulin replacement or not, that they're beneficial, and we have very good proof of concept in patients with type 2, at least for the SGLT2 inhibitors. And of course there have been smaller trials of SGLT1 and 2 inhibition leading up to this. So these are large phase 3 trials, only out over 6 months, but a reasonable time period. And we've been very interested to look at efficacy and safety. So that's why I think these have been very important. So both drugs work. So they both reduce HbA1c by about 0.5%. They reduce weight by about 3 kilograms, reduce blood pressure by about 3 to 4 millimeters of mercury, systolic blood pressure, and they reduce insulin by about 10%. So they both work in that regard. What we've been concerned about has been the risk of adverse events. So some we've expected and they've come through. So genital infections have come through. They're commoner. There's been no increase in severe hypoglycemia with these therapies. And the side effect we've been most concerned about has been ketosis and diabetic ketoacidosis. And what was interesting was that in the dapagliflozin DEPICT study, there wasn't an increase in adjudicated diabetic ketoacidosis. So the DKA rates were the same on placebo, on 5 milligrams, and on 10 milligrams. On the sotagliflozin inTandem studies, there was a 5-fold increase. And it doesn't mean that we're out of the woods with dapagliflozin by any means. There was an increase in ketosis, and we don't know what the level of sort of support, patient education is, how these compared between the trials. The patient groups were of course different, the studies were different. So I think that the concern about ketosis and DK must be there with both therapies. But what I think the DEPICT study showed was that you can give this drug safely to patients, at least in a trial setting. So now we need some more real-world evidence. We need longer trials so that we can look at whether the benefits remain, and also whether these sort of adverse events, whether they settle with time or whether they continue. All the evidence so far is that you're always going to be at risk of some of these adverse events, and they don't go with time. The DEPICT-1 cohort is being followed up longer term, and DEPICT-2 is ongoing and may report next year. So those will happen. We'd love to see trials looking to explore the cardiovascular benefit of these drugs in patients with type 1, like we've seen for type 2. So those sorts of trials need to happen. And I think as a community we need to think about if and when these are licensed, and how do we safely roll these out. So We've heard that generally we think that this should be prescribed in secondary care under specialist advice. We need to be very careful about our patient selection and ensure they're educated, as are our colleagues, as well as colleagues in the A&E and the sort of emergency admitting department, so they know that you can have ketosis without an elevated glucose. And we need to have robust guidelines in place that patients can follow if they were to get ketosis.